स्क्रीन कर लें।
Today our lecture is on the hemorrhagic stroke. So first of all, we will discuss on the intracerebral hemorrhage and then other hemorrhages. So what is intracerebral hemorrhage? The hemorrhagic stroke is divided into the intracerebral and intraventricular hemorrhage and one third into the subarachnoid hemorrhage. Okay. Intracerebral hemorrhage is rupture of the abdominal artery or microaneurysm leading into the substance of the brain and formation of the hematoma. But subarachnoid hemorrhage is due to the leakage of blood in the subarachnoid spaces. Sorry, excuse me.
Hello, जी डॉक्टर साहब.
Hemorrhage. ICU is the second most common cause of the stroke, accounting for 10 to 15% of all strokes. Intracranial hemorrhage is significantly higher mortality risk, with 30% mortality estimated ranging from 35 to 52%. And its rate is approximately 5 times greater than the mortality for the ischemic stroke. So, according to the mortality wise, it is 5 times greater rate of mortality than the ischemic stroke. What is the etiology of the intracerebral hemorrhage? The most common etiology is hypertension. Primary hypertensive intracerebral hemorrhage. Other causes are saccular aneurysm, rupture of the saccular aneurysm, eddy formation of the venous and the vascular malformations. The brain trauma is also one of the causes. Another reasons could be hemorrhagic disorder. The patient is already some disorders like leukemia, plastic anemia, thrombocytopenic purpura, or the patient is taking some anticoagulant or thrombolytic therapies. Okay, or patient is hemophilia or hypophosphatemia. Hemorrhage into the primary and secondary brain tumors, alcoholic disease, narcotic overdose, amyloid angiopathy. Amyloid angiopathy occurs in the old age people. Okay, so the most common is the primary intracerebral hemorrhage with the hypertension. Other are the rare causes. The risk factors either the patient has previous history of TIA, hypertension, hyperlipidemia, these are the cardiac disorders. They can lead to the intracerebral hemorrhage, atrial fibrillation, diabetes, sickle cell disease, behavioral disorders, tobacco abuse, alcohol. Another risk factors might be these are the age, gender, heredity, race. These are the non-modifiable risk factors for the stroke. So, rupture of abdominal artery in arterial hypertension is the most common etiology. It is the 60% of intracerebral hemorrhage. The pathophysiology of hemorrhagic stroke is acute hydrocephaly. There will be increase in the blood pressure. The pressure will increase and the blood will leak out. There will be the brain edema. And dislocation of the brain structures, medicine, compression, and leaks. Hematoma resolution occurs in 4 to 8 weeks. Given a cystic theory, for resolving the hematoma will need the 4 to 8 weeks or more. The most common localization is hemorrhage into the basal ganglia or thalamus. Other common sites are Lumbar hemorrhage, brainstem hemorrhage, and the cerebellum. These are least common, but the most common is basically montane hemorrhage. The cerebellum hemorrhage and the lumbar hemorrhage, these are very lethal and they lead to the death. And we need the urgent evacuation in these cases. The clinical signs and symptoms of intracerebral hemorrhage are acute onset with local signs according to the location and the size of the hematoma. It depends on where the hematoma occurs. Okay, which lobe is involved or which part of the brain is involved, the symptom will be according to them. Okay, if it involves the cerebellum, the patient has cerebellar syndrome, or the right or left hemisphere, the patient has hemiparesis or hypostasia. Diffuse neurological symptoms. Headache is very common. Headache is very common in the intracerebral hemorrhage. Headache, nausea, and vomiting. Loss of consciousness. Okay, meningeal syndrome. In small hematoma may be absent, but meningeal signs and loss of consciousness, headache, these are very common features of the intracerebral hemorrhage. How to diagnose intracerebral hemorrhage? We can go for the CT scan. In every time of the stroke, remember you have to go for the CT scan to rule out the intracerebral hemorrhage. Okay, if it is the intracerebral hemorrhage, then you go ahead without wasting the time and no need of the MRI and you perform manage and treat the patient acute management and hypertension management or whatever the reason is. Later you can go for the MRI. Okay. This is the right parietal hemorrhage on the CT scan. With the CT scan brain, this is the right parietal hemorrhage, and this is the surrounding, this brain is surrounding abdomen. This is the basal ganglia bleed and hypothalamus. This is the basal ganglia bleed that is so severe that it leads to midline shift. Okay. This is the acute one. And this is the MRI of the brain. This is not the CT scan. Okay, previous one was the CT scan. This is the MRI. This is the basal ganglia bleed, basal ganglia, and this is the resolving stage. This is the AV malformation, MR angiography, the CT scan of the brain, the MR angiography, and now look at this. This is the AV malformation. This is the AV malformation. The prognosis of intracerebral hemorrhage. What are the good prognostic factors and the bad prognostic factors? The good prognostic factors, the patient is small or superficial hematoma, consciousness of patient is preserved. This is the good prognostic factor. But the poor prognostic factors are like large, deep wounds, depth of the conscious level. The more severe the patient is unconscious, and the greater will be the flexion or extension to the ventral stimuli. The overall mortality ranges from 55 to 65%. 90% of the patient is in the coma. Okay. Now, when a patient comes to here, we have to detect these 8 important 8 D's, remember, in your mind for a stroke. We have to detect the stroke, whether it is the intracerebral hemorrhage, hemorrhagic stroke, or ischemic stroke. Dispatch and deliver to the patient urgently. Go to medium time for the management. Decide what type of the management and what drug you will do prescribe to the patient. Okay. Notify the emergency response immediately. The fast assessment, pre-hospital stroke care, establish the last normal. This is the fastest. What is the fast? This is the face, arm, speech time. Okay. So urgently, according to the guidelines, you have to measure the fast assessment. Immediate general assessment and stabilization. Within 10 minutes, you have to immediately manage management and stabilize the patient. Neurological assessment, within 25 minutes, you have to do the neurological assessment. And the CT scan or MRI within 45 minutes. Do not delay beyond it. Determine the treatment within the 60 minutes, whether it is the hemorrhagic or ischemic. This is the fast A for face. Either the patient has drooping of their eyelid or face is involved, or there is ptosis, or if the arm is involved, hemiplegia, speech, patient has dysphagia, aphasia, or global aphasia, and how much time the patient presents to us. So this is the fastest thing. In the face, you have to look for the both sides of the face move either equally. or there is abnormality in the face, one side of the face does not move as well, or another side. You have to check for the arm width. Normally, both arms move the same, or both arms do not move at all. If the patient has abnormal grip, then I ask the patient to close the eyes, hold both arms out for the 10 seconds. After 10 seconds, the abnormal arm will drift down compared to the other. So this is the abnormal arm. This is the normal arm. This is the normal arm that drift down after 10 seconds. You have to assess the speech. Ask the patient to speak. You can teach an old dog new tricks or something like any sentence like that. Normal patient will use the correct words with no swelling. Abnormal patient will slur down. Okay? Or is the wrong word, or is unable to speak. Okay? So you have to assess this face, arm, speech, and the time. This is the fastest. Within 25 minutes, you have to go for the neurological assessment. Okay, according to the NIH stroke scale, this is the one of the scale for the stroke, or the Gallagher stroke scale. Whatever you perform, either one of them, by a stroke number, or help to determine the appropriate treatment. Also used to monitor worsening or improvement as a predictor of the outcome. Within 45 minutes, you have to check the stroke is confirmed by hemorrhage. Hemorrhage confirmed. The patient is not admitted for the fibrinolytic or administered the aspirin orally if the patient is able to swallow. If the patient is not hemorrhagic stroke, then you have to either go for the fibrinolytics or like TPA, which I told you in the previous lecture, or to give the aspirin. If it is hemorrhagic stroke, then you don't have to give for the TPA or aspirin. Okay? You have to immediately, if the patient is ICU, then you have to follow the hemorrhagic stroke pathway, transfer the patient to appropriate care, consult neurologist, admit the patient to the ICU, possible transfer to the operating room with the need of operation. So acute management is predicting the hematoma expansion. You have to check that whether the expansion, it is the limited hematoma, but hematoma is going on expanding. So urgent neurosurgical reviews have to be taken for the evacuation of the hematoma. Preventing hematoma expansion. Remember, once the hemorrhage occurs, you have to remember in your mind that you have to prevent the hematoma expansion by the blood pressure control, reversing the INR if it is delayed, platelet transfer, or metabolic disorder. We have also checked the monitoring the complications of intracerebral hemorrhage. These complications are like seizures and hydrocephalus. This is the how the expansion of the hematoma occurs. Within first 3 hours, there is increased risk of hematoma expansion, 36% patients, and within 3 years. As the time goes on, there is less chances of hematoma expansion. This is the spot sign. When you go for the CT scan with contrast, the spot sign is if we have to go for the CT scan green with contrast, and you find out a spot that is contrast enhancement in the hemorrhagic stroke. You will find the contrast enhancement, a spot sign, a dot sign. That means your hematoma is going on expand. This is called the spot sign. Now, how we calculate the patient has intracerebral, how much volume the patient has. So this is not a particular level, but for the information, we have to measure the average length and the breadth, okay, and the C for the number of slices. In how many slices the this hyperintensity signals you will find on the CT scan. Suppose you find in the 4 or 6 scale slices, you will find out this hemorrhagic component. You have to first of all take the average length, multiply the number of slices, for example 4, and divide it with the 2. The answer will be, for example, answer is 8 or 10. That is your hematoma. morning after time. This is another ICH score for the mortality. According to this score, you can monitor how much patient will have the chances of mortality or risk for mortality. The volume, ICH volume, it is more than 30 cc, then the risk is 1. If it is less than 30 cc, the risk is 0. Either the patient has intraventricular extension or not, it is supratemporal or intratemporal. If it is intratemporal, the score is 1. You have to check for the age, the GCS score. Okay, so the higher the score, the more chances of the mortality. If the score is 5 to 6, 100% mortality. If the score is 2, then the 26%. If the score is 1, then 13% risk of mortality. Okay, so this ICH score helps you to monitor the risk of mortality in this patient. I already told you to prevent the hematoma expansion, you have to monitor the blood pressure, preserving the INR, platelet transfer, and the metabolic. The blood pressure environment is very important. Okay, patients within 6 hours of the onset of intracerebral hemorrhage, treatment down is to lower the systolic blood pressure below 140 of mercury and control of systolic blood pressure less than 180 of mercury. Okay, these are the guidelines for intracerebral hemorrhage patient presenting with systolic blood pressure if it is 150 to 220 of mercury. And without contraindication to acute BP treatment, lower the systolic blood pressure up to 140 of mercury is a safe method. This is the class 1 level of evidence. Okay, and can be effective for improving the functional outcome. Okay, so we have to decrease the blood pressure up to 140. For ICH patients presenting with systolic blood pressure more than 220, it may be reasonable to consider aggressive reduction of BP with the continuous silent pain and failure BP monitoring. If the patient is deranged INR, or is they are doing some anticoagulant drugs like warfarin or heparin and can have deranged INR, so we have to transfuse the fresh virgin plasma or vitamin K or the vitamin K accumulated and the hormone factors. So, metabolically, if the patient has fever, glycomanage, reduce the antibiotics, you have to monitor the blood pressure, glucose. Both the hyperglycemia and hypoglycemia should be avoided. Systemic screening for the migraine infarction, ECG, cardiac enzyme testing of the ICH is reasonable. A formal dysphagia screen should be performed in all patients before initiating the oral implant. Okay, to reduce the pneumonia risk. We have to monitor the patient's gait, if it is intact or not, and for dysphagia. These are the complications. So we will have to monitor the complications also. The seizures, the patient has hydrocephalus or due to a pulmonary embolism, and we have to treat accordingly. These are the indications. This is the CD brain and the showing the intraventricular extension and the hydrocephalus. Okay, these are the dilated ventricles and the seepage of blood in the ventricles. This is the hydrocephalus, and we have to urgently call the neurosurgeon for the evacuation and the shunt process. Okay. The manifestations of headache, how the hydrocephalus will present with the headache, vomiting, and drowsiness leading to the coma. So, in this case, we have to endovascular as the treatment of the hydrocephalus is the CSF shunt process. Either the cerebroperitoneal shunt or the AVD shunt should be placed so the patient will decrease with the patient with decreased level of consciousness. If the patient is DVT, Then the risk of deviating hemorrhagic patient is 10 to 15% during acute hospitalization. You have to give the intermittent pneumatic compressions, but we use immediately. Graduated compression stockings are not beneficial to reduce the DVT. After 1 to 4 days, after, not on the first day, but after 1 to 4 days, you can start the low 1 level of heparin or infection to prevent the DVT. This is the prophylactic dose of the heparin. Now comes to the subarachnoid hemorrhage. The subarachnoid hemorrhage, what is the etiology? The rupture of aneurysm. In 60 to 70% of the cases is the rupture of the aneurysm. Other causes are circular aneurysm and the AV malformations. The complications in treatment with anticoagulants or thrombolytics can also lead to the hemorrhage. Either the patient has a neurological disorder or the unknown reason. These are the intracranial aneurysm, and the rupture of these will lead to the dilatation of the cerebral arteries and thinning and weakening of the vessel wall. These are the AV malformations. Okay, AV malformation is an aggregation of the arterial and the venous communications with no intervening capillary network. In vitro, this is the abnormal arterial and venous combination, and they have no intervening capillary network. The most common presentation of the subarachnoid hemorrhage is the severe headache, one of the severe headache of the slide. Severe thunderclap headache, along with the managing signs like neck stiffness, stunning signs, nausea, vomiting, and photophobia. The patient has loss of consciousness, epileptic seizures can occur. Psychomotor excitation means the patient has irritable, restlessness, agitation, psychosis, and hypertension. Reactive hypertension means the patient has, along with the hypertension, the patient has hyperthermia and tachycardia. Okay, so these are the most common features: severe thunderclap headache, the most severe headache of the patient's life, and the loss of consciousness, not only in photophobia, managing signs, the patient can present the seizures. You have to go again for the CT scan brain to be about subarachnoid hemorrhage. CT scan brain is not 100% subarachnoid hemorrhage is not present on CT scan, but if it is not present, then you have to go check for the lumbar puncture. You will find out the frontochromia and MR angiography or contrast cerebral angiography to look for the abnormal aneurysm. This is the subarachnoid hemorrhage. And this is the subarachnoid. This is CT brain and this is the MR. Lumbar puncture, check for the understanding the cerebral ability, xanthochromia because of the aggregation of proteins in the subarachnoid space. What is the prognosis of subarachnoid hemorrhage? It is high fatality, ranging from 30 to 70%, and depends on the severity of the initial hemorrhage. Among those who survive early rebleeding and delayed ischemic neurological deficits from vasospasm can cause serious mortality. How we manage the intracerebral in the subarachnoid hemorrhage? In cerebral hemorrhage, we have to remove for the hematoma. In subarachnoid hemorrhage, we have to go for the clipping or coiling of the aneurysm. In both of them, we have to monitor the blood pressure, ECG, blood glucose, electrolytes, prevention and the treatment of the complications, and the rehabilitation. This is the treatment of both. Okay? The treatment of subarachnoid hemorrhage is strict bed rest, surgical treatment in presence of aneurysm. If the patient has aneurysm, then we have to go for the surgery, either clipping or coiling. Okay? We have to give the calcium antagonist like nimodipine. Okay. Prevention for the secondary vasospasm. Monitor the blood pressure, ECG, blood glucose, and the electrolytes. If the patient has severe headache, we have to give some analgesics. Okay. This is the coiling embolization, the coiling of the aneurysm is performed. Okay. The coil is transferred, and we have to a platinum coil is inserted through a muscular wire, and then we have to secure the aneurysm. This is the open method of clipping. The complications of cerebral hemorrhage are cerebral vasospasm, and the vasospasm leads to the ischemic stroke again. Patient may have the recurrent cerebral hemorrhages. Again, the patient has brain edema and the hydrocephalus, like as it is in the intracerebral hemorrhage. So, this is all about the intracerebral hemorrhage and the subarachnoid hemorrhage, its pathophysiology, and the treatment and complications. So, we have completed the ischemic stroke, and we have also completed the hemorrhagic stroke. Okay. That's all about the today's lecture. Please ask me.